Hello, welcome to my Borderpolar podcast, Series 1, Episode 1. What is Borderpolar? This series is called a Borderpolar Diagnosis, and the first episode is called What is Borderpolar? If you watched my welcome video, then you would know that the purpose of this podcast is to share my experience as someone diagnosed with borderpolar, which I'm going to talk about now is a dual diagnosis of borderline personality disorder and bipolar disorder. Borderline personality disorder is a personality disorder by definition, but more than that, it's an emotional dysregulation disorder. Um, Emotional dysregulation being one of the major symptoms. Bipolar disorder is a mood disorder. So in that, they're defined differently in psychology. Borderpolar is a non-diagnostic term. And what I mean by that is you aren't going to hear psychiatrists and psychologists using the term borderpolar to describe someone with a dual diagnosis. However, I like using it to talk about my own diagnosis because defining myself as someone with borderline personality disorder is not all-inclusive, and neither is defining myself as someone with bipolar disorder because the symptoms that I deal with are bigger than that. So I like the term borderpolar. And if you look at the numbers, approximately 1.4% of the United States population has borderline personality disorder, and approximately 2.6% of the United States population has bipolar disorder. Comorbidity, an overlap between two disorders, happens in about 20% of people with bipolar and BPD, meaning that 1 in every 5 people with borderline personality disorder will also have a diagnosis of bipolar, and 1 in every 5 people of bipolar disorder will also have a diagnosis of borderline personality disorder. So there's a 20% of comorbidity there. If I did the math, and what I came out with is between 924,000 and 1.7 million people have a borderpolar diagnosis in the United States. So roughly 0.3 to 0.5% of the United States population is by distinction borderpolar. However, borderpolar is not a distinction in psychology. Should it be? I don't know. Do I think that people with this dual diagnosis need a place to find information to deal with it? Yes. So that's what I'm trying to sort of cultivate. What does bipolar look like? To talk about borderpolar, you have to know what bipolar looks like, and you have to know what borderline personality disorder looks like. So when you talk about what does bipolar look like, what does BPD look like, and BPD is a shorthand for borderline personality disorder. I'll probably use that a lot, BPD. Some people in the mental health community, mental health patients will use BPD to shorten bipolar disorder, but generally BPD is used as a shorthand for borderline personality disorder, and bipolar might be shorthanded to like BP1 or BP2 to signify whether you have bipolar disorder 1 or bipolar disorder 2. So when you talk about what does a disorder look like, you're talking about the symptoms that a person exhibits. Now with bipolar disorder, you have two different types of symptoms. You have manic symptoms and you have depressive symptoms. It used to be called manic depression, which is a very descriptive and accurately descriptive way to categorize the symptoms of bipolar disorder. The manic symptoms seen here on the screen include extreme happiness, hopefulness, and excitement. Strangely enough, irritability, anger, fits of rage, or hostile behavior can be part of manic symptoms too. Restlessness and agitation, rapid speech. Sometimes it might feel like a forced speech, like where you feel like you have to keep talking, Agitation, I said that already. Poor concentration and judgment, increased energy, decreased need for sleep, unusually high sex drive, setting unrealistic goals, and in some cases, paranoia are part of manic symptoms. Now we'll take a look at the depressive symptoms of bipolar disorder. The depressive symptoms will include sadness and crying, feelings of hopelessness, worthlessness and guilt, loss of energy, loss of interest or pleasure in everyday activities, trouble concentrating and making decisions, irritability, a need for more sleep or sleeplessness, change in appetite, weight loss or gain, and suicidal thoughts or attempted suicide. So when you're talking about manic symptoms and depressive symptoms, you're really talking about how manic am I, how depressed am I on each given day. And we'll go into that a little bit more, not even just each given day, but each given moment. And we'll talk about that more with the flavors of manic and the flavors of the depression as we go on. So we talked about what does bipolar look like, the manic symptoms, the depressive symptoms. Now what does BPD look like? What are the symptoms of BPD look like? BPD looks like a distorted self-image, feelings of isolation, boredom, and emptiness, mood swings, sometimes severe and sudden, feelings of anxiety, loss of interest in routine activities, suicidal thoughts. Now you'll start seeing that some of these symptoms are going to be symptoms that you see in common with the depressive symptoms of bipolar or the manic symptoms of bipolar. And we'll go through these real quick and then I'll talk more about that. They also include delusion, long-term pattern of unstable relationships, strong emotional reactions. That ties into that whole, I was mentioning that this is an emotional dysregulation disorder, and also self-harm or other dangerous behaviors. So some of these symptoms, as you can see, overlap or are the same as the symptoms of mania or depression in bipolar. And in my first welcome video, I talked about how when you're diagnosed with these mental health disorders, you sort of have to think of these symptoms as like colors of a palette on a palette scheme. So you have like shades of red that are just slightly different from one another, all lined up in a row. And let's say, you pick 7 of these symptoms, these shades are like symptoms. You have to have these 7 symptoms or these 7 shades in order to qualify for one certain disorder, or these 8 in order to qualify for a different disorder. But sometimes they're going to overlap. They're going to have the same symptoms in separate disorders. So that's why you're going to have a lot of comorbidity. Now the impact of comorbidity. Let's talk about that. Amongst patients with bipolar disorder, those with comorbid BPD, so people who have both bipolar and borderline, reported more mood episodes, an earlier age of onset of bipolar disorder, greater suicidality. If you don't already know, then I will tell you that the mortality rate for borderline personality disorder is 10%. So 1 out of every 10 people who are diagnosed with borderline personality disorder takes their own lives. Greater hostility and a higher prevalence of substance abuse. So the main idea is that when you have bipolar disorder, life is rough. When you have borderline personality disorder, life is rough. When you have them both, life is a little more rough, it seems. I can't know because I'm only me. But according to a study called the Midas Project, where they compared psychiatric outpatients with borderpolar, or both borderline and bipolar, to patients with BPD without bipolar and patients with bipolar without BPD, they hypothesized, or they thought, that the borderpolar patients would have significantly more psychosocial morbidity, significantly more problems with the way that their internal thoughts and feelings relate to social factors. That's what psychosocial morbidity means. How your disorder or disease affects your social factors, and in this instance, the social factors are influenced by your individual thoughts and behaviors. That's what psychosocial has to do with. Morbidity is how a disease affects you. And they would hypothesize that the borderpolar patients would exhibit significantly more psychosocial morbidity than patients with only one of these disorders, meaning that it would make a bigger impact on their lives, I think, make it a little bit more difficult to function, and make it a little bit more difficult, more importantly, to treat. And I think that's why they did this. And the project was called the Rhode Island Methods to Improve Diagnostic Assessment and Services Project. So the idea was to look at these groups of people in order to see if they could improve how they diagnose and how they assess these groups of mental health patients. In this specific study, they had, if you see n equals 59 on the screen here, next to borderpolar, that means that there were 59 people in their study that had a dual diagnosis of borderline and bipolar. N equals 330 means they had 330 people in their study of people that had a diagnosis of borderline personality disorder without bipolar disorder, and N equals 128, meaning that they had 128 people in their study that had a diagnosis of bipolar disorder without borderline personality disorder. The results of the MIDAS project showed that significantly more patients with borderpolar had diagnoses of 3 or more Axis 1 disorders. Now, these Axis 1 disorders are going to be anxiety disorders, disruption disorders like ADD, anxiety disorders like social phobias, major depressive disorder, things like that are Axis 1 disorders. You're going to see a lot of comorbidity. They had significantly more with 3 or more of these. Borderpolar patients reported significantly more PTSD, OCD, substance use disorder, which is another Axis 1 disorder, and somatoform disorders compared with patients with just bipolar disorder. And also borderpolar patients reported significantly more OCD than patients with just borderline personality disorder. And these are just some of the findings from this study. The borderpolar patients in this study had the most psychopathology in their first-degree relatives. So it seemed like they had relatives with more mental health problems than those without both borderline and bipolar. Compared with patients with bipolar disorder, the risk for developing depression, PTSD, specific phobias, and drug and alcohol use disorders was significantly higher in the borderpolar patients as compared with the bipolar disorder patients. Compared with specifically the patients with borderline personality disorder, the borderpolar patients had higher risks for developing PTSD and drug and alcohol use disorder. Now, that's not that surprising. If you've researched about BPD, you will see that a lot of people with BPD also have comorbid PTSD, which makes sense because although you don't need to have a traumatic event in your childhood to end up with a diagnosis of borderline personality disorder, a lot of people do, and which also unfortunately means that you end up having a lot of times a diagnosis of PTSD because you exhibit a lot of those symptoms as well. They've also found, if you read the book I Hate You, Don't Leave Me, Understanding Borderline Personality Disorder, they found a strong correlation between people with impulsive disorders such as drug and alcohol use disorder and also eating disorders have a high correlation of diagnosis of BPD as well, borderline personality disorder. So all together in the MIDAS project results were that the psychosocial morbidity, or the impact of the disease on the social aspects of life, was greatest in the borderpolar patients. And the borderpolar patients were more likely to receive disability benefits in those cases. Not saying that that is a rule for thumb, but this is what the MIDAS project found. More results from the MIDAS project were that the borderpolar patients reported more episodes of depression, more anger, more suicidal ideation, more childhood trauma, more chronic and persistent unemployment. I've actually looked into this, and one statistic I found is that 1/3 of people with borderline personality disorder are able to hold full-time jobs successfully. Impaired social functioning, history of suicide attempts, and psychiatric hospitalizations. So what we're getting from this is that the impact of comorbidity for people that are borderpolar is big. It's big. And the thing is that when I went out looking for support for this, and I looked at bipolar support groups, and I looked at borderline personality support groups, neither one of them felt like me. Neither one of them felt like they were explaining what I go through. And this borderpolar distinction, I think, is something that we need to cultivate a little bit more so that we can have a community where we can discuss what it feels like to have both of these disorders concurrently. I know that there are a lot of people out there in the mental health field that have concurrent disorders. I see people asking all the time, does anyone have borderline personality disorder and ADD? Does anyone have borderline personality disorder and OCD? And people are looking for this group, this community that fits just right with them. And I'm probably not going to find a large community of people who have borderline personality disorder 1, or borderline personality disorder, bipolar disorder 1, PTSD, social phobia, or social anxiety disorder, and all the exact specific diagnoses that I have, impulse control disorder. I mean,
that's probably not going to happen. But I think that borderpolar in and of itself affects enough people that it requires this distinction. So now we're going to touch a little bit on just diagnosis and mental health in general. If this is something that's new to you, something you aren't used to, then maybe it would be beneficial to know what the difference between a psychiatrist, a psychologist, and a therapist is. So a therapist is a term that you can use to discuss anyone you're going to talk to your problems about and then pay them for. So a psychologist can be called a therapist, but a psychologist is specifically a doctor of psychology, someone who's received that degree, or a doctor of philosophy. Whereas a psychiatrist is a medical doctor or a doctor of osteopathy, an MD or a DO. So the difference between those two things is that they both went to a 4-year school. They both had an education through their doctorate degree. However, a psychiatrist had to complete medical school and a 4-year residency, is allowed to prescribe medication under all circumstances, and typically doesn't do talk therapy. That's the distinction between a psychologist and a psychiatrist. So a psychiatrist is who you're going to go to for your medicine. A psychiatrist is important. Psychiatrist you're going to see 4 to 6 weeks, maybe every 8 weeks, depending on what you're prescribed, but you're not going to spend an hour once a week with a psychiatrist discussing your hopes and fears and dreams. That's for a therapist or a psychologist. Now, the difference between a therapist and a psychologist is that a psychologist has gone through a 4-year college and education through a doctorate degree, but they did not have to go through medical school, and they did not require a medical residency. They can prescribe medicine in certain states and under certain circumstances. For example, I believe in military and things like that. Typically, they do talk therapy, so psychotherapy, cognitive behavioral therapy, and so forth. A therapist, on the other hand, does not necessarily have to have gone through any sort of formal training. They should have training, but it is not required for someone to call themselves a therapist or a counselor. So you want to look into what credentials someone has. They do not prescribe medication, and they can conduct all types of counseling and therapy. They can be life coaches. They can be licensed counselors. They can be licensed therapists. They can have a degree in psychology. Maybe they could have a degree in biology. They could have a degree in pretty much anything if they went to college. They could not have gone to college and could have taken a certificate course or several certificate courses. So you want to kind of look into a therapist and find out what their credentials are. If you're dealing with a psychologist, you know what their credentials are. But with a therapist, you want to know what their credentials are and what they've specialized in and what they've already dealt with if you're dealing with a borderpolar diagnosis, in my opinion. I am not a medical doctor, and I cannot give you medical advice. But in my opinion, you want to know what your therapist's credentials are when you're dealing with a borderpolar diagnosis. Because it would be beneficial to have a therapist who understands the borderpolar diagnosis if that's what you're dealing with. So let's talk a little bit more about a psychiatrist. The psychiatrist will often treat people with a mental health condition that requires medication. We talked about that. They're going to diagnose using psychological tests, one-on-one evaluations, lots and lots of questions. They might use lab tests to rule out physical causes of symptoms. Psychiatrists are going to closely monitor you for signs of improvement and any side effects of your medication. So when you're first starting a medication, you might see your psychiatrist more often than after you've been on one for a while, because they're going to need to monitor you for side effects and for whether or not you need to increase or decrease your dosage. They may prescribe things like electroconvulsive therapy or light therapy. So your psychiatrist is going to be your most highly qualified member of your mental health team. A psychologist, on the other hand, still works with people who have mental health conditions, but typically isn't prescribing medicine. They diagnose using interviews, surveys, and observations, and they typically treat people with talk therapy, such as cognitive behavioral therapy or dialectical behavioral therapy. Therapy with a psychologist can take many forms. You can do one-on-one therapy, family therapy, group therapy. Group therapy is important in DBT, is often important for people with substance abuse problems, eating disorders, things like that. Family therapy is extremely important for people with mood disorders and emotional dysfunction. All types of therapy are beneficial. A therapist, in my opinion anyway, are professionals who are trained to provide treatment and rehabilitation. Yes, they will work with mental health patients, but they should be trained. But you have to be careful because someone can call themselves a therapist without having been trained, so check your credentials. They may or may not have a professional degree, but they may or may not have a certification as well. The term therapist is often applied to psychologists, but it can include others who provide a variety of services: social workers, counselors, life coaches, many others. You will hear people call a psychologist a therapist, but know the difference between the two. Let's talk a little bit about diagnosis and what is the DSM-5. Well, the DSM-5 is the Diagnostic and Statistical Manual of Mental Health Disorders, and it's the 5th edition. It's the 2013 update to the Diagnostic and Statistical Manual of Mental Disorders. Basically, this is the book that they use. It's the taxonomic, and taxonomy is how you categorize things. It's the taxonomic and diagnostic tool published by the American Psychiatric Association. So in America, we use the DSM-5 right now to diagnose and figure out the treatment for, I don't know if they used it for the treatment for, to diagnose mental illnesses. So you have in the DSM-5 the list of mental illnesses and what their symptoms are. I've never looked at this book myself, but I do know that they use it to diagnose mental illnesses. And so when you're talking about the symptoms of bipolar disorder, the symptoms of borderline personality disorder, you're specifically talking about those qualifying symptoms that they include in the DSM-5 to say, yes, if you have 5 of these 9 symptoms, yes, if you have 3 of these 7 symptoms, yes, if you have X number of these symptoms, then we are going to say that you have this disorder. All that really means is that when they give you the name of a disorder is a word that doctors everywhere can use to understand the best general way to go about treating what you're dealing with. But I think people get hung up on these names so much when really the important thing is to focus on what are your symptoms and what can you do best to function better in your life to make those symptoms less troublesome for you. So when you're talking about the symptoms that you have, we're talking about as they're listed in the DSM-5. We went over the basic idea of what borderline personality disorder looks like, what bipolar disorder looks like. Now we're going to go specifically as what is listed in the DSM-5. So when you go see your psychiatrist, when you go see your psychologist, when you're first diagnosed with this disorder, this is what they're going to be looking at. Okay, so the diagnostic criteria as listed in the DSM-5 for borderline personality disorder is right here on the screen. To have borderline personality disorder, you would be described as someone with a pervasive pattern of instability of interpersonal relationships, self-image and affects, and marked impulsivity, beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following. So if this description fits you and you have 5 or more of these symptoms, then a doctor would say that you have what is called borderline personality disorder, which effectively just means you have a certain set of characteristics that you need to understand how they work and how they impact your life and what you can do to change that, to make your life less impacted by them, basically. That is the burden on someone with a mental illness. So here are the 9 symptoms for borderline personality disorder. I'll give you a little bit of insight into me. I exhibit all 9 of these symptoms. Not everyone does. Some might exhibit 5, 6, 7, 8, 9. And because you can exhibit 5, 6, 7, 8, 9, and they can be of varying numbers, I think there's something like over 200 different combinations of ways that these symptoms can manifest themselves in one human individual. So when you talk about someone having borderline personality disorder, one person to the next, to the next, to the next isn't necessarily going to understand what the other person is going through. So, number 1, frantic efforts to avoid real or imagined abandonment. And there's a note here, and they're going to note this a couple of different times, that this does not include the suicidal or self-mutilating behaviors covered in Criterion 5. So any efforts would be covered in Criterion 5 if they have to do with suicidality or self-mutilation. So frantic efforts to avoid real or imagined abandonment. And we're going to go through these symptoms later and talk about how they relate to changes in the brain in another video. Number 2, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. Now, we'll talk about that more in other videos too. That has to do with black or white thinking or splitting, if you've heard those terms in BPD. Number 3, identity disturbance. Markedly and persistently unstable self-image or sense of self. So anyone out there who has BPD and has looked in the mirror and thought, who the hell are you? That's why. We'll talk more about these symptoms later, but identity disturbance, markedly and persistently unstable self-image or sense of self. Impulsivity in at least 2 areas that are potentially self-damaging, and this again does not include suicidality or self-mutilating behavior that's covered in Criterion 5. So some of the examples of these impulsivity would include spending, sex, substance abuse, reckless driving, binge eating, other things like that. Number 5, recurrent suicidal behavior, gestures or threats, or self-mutilating behavior. Number 6, affective instability due to a marked reactivity of mood. For example, intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. So here you're talking about mood swings that can be rapid or extreme. And also that same emotional dysregulation, marked reactivity of mood has a lot to do with emotional dysregulation, I think. Number 7, chronic feelings of emptiness. This is one that sometimes is really hard for people to define. I had this pit in my stomach that I could describe as an empty pit in my stomach my whole life, but I didn't know until I was 35 and I was diagnosed with borderline personality disorder that having this empty feeling, this empty pit in my stomach, was a symptom of a disorder that I had had my whole life. And I never knew. I always thought it was just a flaw. Inappropriate, intense anger, or difficulty controlling anger. Frequent displays of temper, constant anger, recurrent physical fights. I had a lot of trouble with this symptom when I was diagnosed with borderline personality disorder because I am a pacifist and I am nonviolent and I am not an angry person. But I realized that I do have inappropriate, intense anger and difficulty controlling my anger. I just didn't have it outwardly. I had it inwardly. My anger and rage is in here. I just never let it out. I let it seethe, but it was always there. So I had a lot of trouble with my diagnosis based on that right there. I said, I can't be borderline. I'm not mean. But that's just not true. That's a stigma. It's a stigma. And it's a stigma that I'm looking to stop. Transient stress-related paranoid ideation or severe dissociative symptoms. That's a big sentence. So paranoia. You get stressed because you're paranoid. Sometimes you get looped into your own paranoia. That's that paranoid ideation where you're going over and over those thoughts over and over again. Severe dissociative symptoms. Dissociation is sort of like an out-of-body experience where you sort of feel like you're there, but you're not there, in a fog. People have a lot of different ways of describing dissociation. We'll talk about that more later too. So that's borderline personality disorder according to the DSM. So here we have the diagnostic criteria from the DSM-5 for bipolar disorder. For bipolar disorder, you have 2 distinctions, bipolar 1 and bipolar 2. The major difference between bipolar 1 and bipolar 2 disorder is the presence of a manic episode or a mixed episode. In bipolar 1, you've had the presence of at least one previous manic episode or one previous mixed episode. But in bipolar 2, you've never experienced a full-on manic or mixed episode. We're going to talk more about what makes a manic episode, what makes a mixed episode. It has to do with the flavors of your symptoms, whether you have more manic symptoms, more depressive symptoms at any given moment, and how many at any given moment and for how long. So we'll talk more about that in another graphic. Here are the diagnostic criteria for a major depressive episode, which is half of the criteria for diagnosing bipolar disorder. The depressive symptoms of bipolar disorder are listed here 1 through 9. Specific to the DSM-5, here are the 9 symptoms. Depressed mood most of the day, diminished interest or pleasure in all or most activities, significant unintentional weight loss or gain, insomnia or sleeping too much, Agitation or psychomotor retardation noticed by others. So that's going to be speaking too fast or too slow that other people notice, moving too fast or too slow that other people notice, being agitated that other people notice, fatigue or loss of energy, feelings of worthlessness or excessive guilt, a diminished ability to think, concentrate, or indecisiveness, recurrent thoughts of death. And you have to have at least 5 of these symptoms that cause clinically significant distress or impairment in your social, occupational, or other important areas of your functioning for at least 2 weeks, most days, almost every day. And at least 2 of these symptoms should be a depressed mood or the loss of interest or pleasure to qualify you for a major depressive episode, which is half of a bipolar 1 diagnosis. The second half is a manic episode diagnosis. So the 7 symptoms of a manic episode include an inflated self-esteem or grandiosity, a decreased need for sleep, feeling rested only after just a few hours, being more talkative than usual or a pressure to keep talking, flights of ideas or racing thoughts, making it feel like your thoughts are racing. It's a subjective experience, being easily distracted by unimportant, irrelevant things, increase in goal-directed activity at work, socially or sexually, or psychomotor agitation, non-goal-directed activity, maybe some fidgeting, some pacing. For me, that's what it is, fidgeting and pacing. Excessive involvement in activities that have a high potential for pain consequences. Here's your risk-taking behavior. So you have your bipolar spending, people will say that. Engaging in unrestrained buying sprees, sexual indiscretions, or foolish business investments. And these manic episodes are a distinct period of abnormally and persistently elevated, expansive, or irritable moods, or abnormally and persistently increased goal-directed activity or energy, lasting at least 1 week for a manic episode. Now, over 4 days, I think, is hypomanic. I'm not positive, but for 1 week to be a manic episode. And during the period, 3 or more of those symptoms, or 4 or more if you're irritable but not elevated, would be present. Now here's the difference between mania and hypomania, the difference between those 4 days and those 7 days. So I did have it right, so 4 days. So hypomania is going to last at least 4 days, and you can experience that with bipolar 2. But with bipolar 1, you're going to have a manic episode that lasts at least 7 days. Mania is causing severe impairment in your social or occupational functioning, where with hypomania, you don't have a marked impairment in your functioning. Now that might not seem real to the person experiencing the hypomania. They may feel like there is very much an impairment. So you have to remember that these qualifications are coming from the outside. A mania may necessitate hospitalization to prevent harm to self or others, where a hypomania does not require hospitalization. That is a very big distinction. No, mania doesn't have to have hospitalization, but a hypomania is not going to require that. And a mania may have psychotic features, and a hypomania won't. So we're talking paranoia, delusions, things like that. Now here is the graphic I was talking about, where we can look at what is mania, what is a mixed episode, what is a depressive episode. So we talked about those depressive symptoms and those manic symptoms on those last couple of slides. If you look here where it says elevated mood in green, greater than 3 and less than 5. Greater than 3 manic symptoms, less than 5 depressive symptoms is what will constitute you as having a manic episode. On the other end, a depressive episode in red, up above you can see is less than 3 manic symptoms, greater than or equal to 5 depressive symptoms will qualify you as having a depressive episode. Whereas right in the middle, a mixed episode, which is a feature that you see in bipolar 1, but not in bipolar 2, is a mixed episode. Up until I was diagnosed with borderline personality disorder in 2018, I had qualified my bipolar as being 85% mixed episodes, because I always felt like I was exhibiting more than 3 manic symptoms and more than 5 depressive symptoms at the same time almost all the time. However, I felt depressed, very depressed for a large part of my life too, so it was all very confusing to me. And when I got the diagnosis of borderline personality disorder, it made a lot more sense that I couldn't quite fit my moods into this chart on a given day. But now that I know the flavors of borderline and the flavors of bipolar, it's a lot easier for me to be able to sort of figure out what's causing me trouble on a given day. not great yet, but I'm working on it. Let me put it that way. I'm working on figuring it out. So this is a neat graphic. If you aren't that familiar with the flavors of bipolar disorder, if you can take a look at your symptoms on a given day, your manic symptoms, your depressive symptoms, and sort of figure out where you're at in here, for some reason, knowing where you are makes it easier to handle for me. I don't know if knowing where you are will make it easier to handle for you, but I really liked this graphic a lot. Moving on to treatment. We're not going to talk a whole lot about treatment in this video. That's for another one. We're going to touch on it a little bit. Treatment for borderline personality disorder is a focus on psychotherapy, a focus on talk therapy, with possible adjunctive medication, so possible medicine to help. So therapy first, one, medication if needed. That's BPD. Bipolar is different. Medication first, therapy if needed. These are important things to remember if you have these diagnoses. Borderline, therapy first, medication maybe. Bipolar, medication yes, needed. Therapy maybe, depending on who you are and what you have to deal with. But that is important because there is no specific medication to treat borderline personality disorder. There are medications that can treat some of the symptoms, but there are specific medications to treat the major symptoms of bipolar disorder. Talking about medication specifically, and we're only going to go into this a little bit, and remember, I am not a medical doctor. We are not going to talk about every medication. We're not going to talk about side effects. We're going to just touch a little bit on what you might hear about. For borderline personality disorder, medication is the second line of defense. What's the first line of defense? Therapy. For borderline personality disorder, the first line of defense is therapy. The second line of defense could be medication, and that can include things like antidepressants, antipsychotics, and mood stabilizers. For bipolar, the first line of defense is medication. For bipolar, the first line of defense is medication, and that includes things like mood stabilizers, antipsychotics, antidepressants, anti-anxiety drugs. You can use anti-anxiety for borderline personality disorder too. That's up to your psychiatrist and you. A little bit about the medication and borderline personality disorder and antidepressants. So for borderline personality disorder, antidepressants are the most commonly prescribed in the category of SSRIs. So they're most commonly prescribed as selective serotonin reuptake inhibitors. If you've heard of SSRIs, are supposed to help treat depression for borderline personality disorder. An antidepressant in bipolar disorder could help treat depressive symptoms, sure. It can also help stabilize mood swings. And you see some examples here on your screen. Fluoxetine is something that I take for a little bit of information about me. It's the generic of Prozac. I have not taken anything else on this screen here, but I do recognize these names from some of the support groups that I'm in online. Moving on to talk about antipsychotics. So antipsychotics in borderline personality disorder are going to help stabilize certain brain chemicals. Brain chemicals are called neurotransmitters. Neurotransmitters take messages from one neuron to another throughout your body and make everything happen. In your mental health, they're going to help to control emotion and behavior. So antipsychotics to help to stabilize these brain chemicals, these neurotransmitters. Included here are risperidone and a couple others. I take risperidone. I have seen quietapine mentioned a lot in my groups. So it must be a drug that people prescribe a lot for borderline personality disorder. Bipolar disorder, antipsychotic drugs are to help reduce symptoms of psychosis, such as illusions, hallucinations, perhaps paranoia for either one. I have not taken any of those medications under the bipolar listing there. Next, we'll talk about mood stabilizers and anti-anxiety drugs. Anti-anxiety drugs are going to reduce your anxiety. They're pretty self-explanatory. There's a lot of examples there at the bottom. I don't take any of those at the moment. Bipolar disorder, mood stabilizers are going to help control those extreme mood variations. I take lamotrigine, or Lamictal is what it's called. And that's on the list there. There's a few others listed. The mood stabilizer under borderline personality disorder could be prescribed to help reduce anger, to help reduce anxiety, depression, impulsivity, or attempts at self-harm. So a mood stabilizer can be prescribed for either disorder, but it is very important to remember that the very first line of defense for borderline personality disorder is therapy. You cannot treat borderline personality disorder with medication alone. Types of therapy. Borderline personality disorder therapy is the first line of defense. Psychotherapy or talk therapy, specifically dialectical behavior therapy, is shown to be so far the best treatment for borderline personality disorder in general. It's going to be different for everybody. There are other options that we will talk about in a different video. For bipolar disorder, therapy is the second line of defense, the first line of defense being medication. Bipolar, meds first, therapy second. Borderline, therapy first, meds second. So for bipolar disorder, psychotherapy is your second line of defense. You can also include other types of therapy like electroconvulsive therapy, transcranial magnetic stimulation or TMS. There's other types of therapy that go along, EMDR. There's quite a bit out there, and we'll talk more about those in another video. For borderline personality disorder, psychotherapy is where a trained therapist, like I said, talk therapy, can provide assistance, managing your thoughts, feelings, and emotions. Very, very important in an emotional dysregulation disorder. Dialectical behavior therapy is a type of cognitive behavior therapy, a type of talk therapy that provides guidance in adapting your changes in behavior, in taking the changes that you need to make in your behavior, adapting them to your life. I have not gone through DBT. It has a few core values or core concepts that include mindfulness, distress tolerance, radical acceptance, all very nice concepts that I'm excited to explore with you as we move on in these video series. But I have not gone through DBT myself. I do plan to discuss it at length in these videos, however. Types of therapy for bipolar disorder: psychotherapy, electroconvulsive therapy, transcranial magnetic stimulation. Psychotherapy, again, interpersonal, social rhythm therapy, cognitive behavioral therapy, talk therapy. This can be individual or family focused. ECT, or electroconvulsive therapy, is where they pass mild electrical currents to the brain to alter the chemistry and functioning. And transcranial magnetic stimulation is where they apply a magnetic field to the brain to alter its functions. And that's still being tested according to the research that I found. I don't know a lot about it, but I will look into these and talk about them more in another video, as you'll see coming up. So this is a borderpolar diagnosis. That's what this video has been. What is borderpolar? Just a basic overview about what borderpolar is and what kinds of things we're going to be discussing. Most of what I talked about in this video, I'm going to go over in much more depth in the upcoming videos. Just coming up, episode 2 is going to be called Understanding Borderpolar. In that, we're going to go into a lot more depth about the intricacies of bipolar and the intricacies of borderline personality disorder, the symptoms and how they manifest themselves in people's lives, how I can relate to those symptoms myself. I'll bring in some case studies from things that I've read and things that I find online, and we'll talk a lot more about what those two things look like and feel like as best as we can speak about such a thing in a little while. Episode 3, what loved ones need to know. Everybody wants to know when to tell loved ones, what to say to them, what kind of resources you can point your loved ones to in order for them to best understand what you go through. So we'll talk in episode 3 about what loved ones need to know. Episode 4 I'm excited about because the biology nerd in me, the teacher in me, the science geek in me is really excited about learning more about our brains and how they work and why they work the way that they do. And so it's called Navigating Your Brain, and I'm going to look into those symptoms, and I'm going to figure out what in your brain isn't functioning right to cause those symptoms, and we're going to figure out why we are the way we are, and I'm excited about that. And following that, we'll talk about in episode 5, what's next, treatment and recovery, where we'll expand on some of the stuff we talked about here, different types of therapy, different types of medications, stuff like that. Again, I am not a doctor. I cannot give you medical advice. This is just information with resources at the end. And episode 6, my borderpolar journey. I'm going to give you a little bit more about what I've been through in my diagnosis and in my journey of discovery and growth and healing and kind of the struggles that I've had to overcome. Just a little bit about me, not too much, but just a little bit so that you can help understand what we may or may not have in common and a better way to relate to the information that I'm putting out there and how I'm putting it out there. Because it's always going to be different to you than it is to me. Following that, my next video series, and I have a trouble with procrastinating, so don't expect these to come out super fast. And I have to do a lot of reading and research, but I'm hoping that I can get at least one out every month, if not more than one. But the next video series is going to be the borderpolar parent. And in the Borderpolar Parent, I have 6 videos planned: what and when to tell the kids, what to expect when you're exploding, how to forgive yourself, how to apologize for your actions, what I wish I would have known, and value-based parenting. And I am a parent of 2 lovely children, both elementary school aged, and I can speak about what it's like to be a borderpolar parent for sure. And that is what I'm going to do in the next video series. Here we have some references I'm going to leave you with if you feel like taking a look at that. This is where I got my information, and the rest of it just came from what I remember from all the things that I've read and thought and learned about since my first diagnosis back in 2005. Thank you for joining me for a Borderpolar Diagnosis Series 1, Episode 1. What is borderpolar? Have a nice day.